Okay, welcome everybody to our grand rounds. My name is Patricia Lester, and I have the privilege of introducing my colleague, Dr. Elizabeth Bromley. I'm going to share with you kind of a more formal introduction and just a few comments about our work together. So Dr. Elizabeth Bromley is an associate professor in residence in the Department of Psychiatry here at UCLA. She's a faculty member in the Center for Health Services and Society at the Semel Institute. She's also affiliated with the UCLA Department of Anthropology, the Desert Pacific Mental Illness Research, Education, and Clinical Center at the West Los Angeles VA, and the RAND Corporation. She's a board-certified psychiatrist as well as a medical anthropologist, and she received her MD and MA in the history of medicine from UCSF. So we both went to UCSF. And her PhD in anthropology from UCLA. She completed residency and a chief residency in psychiatry at Columbia University and the New York State Psychiatric Institute. She's a graduate of the VA UCLA Robert Wood Johnson Clinical Scholars Program. And between 2004 and 2018, she was the medical director for the VA Mental Health Intensive Case Management Program, an assertive community treatment team serving veterans with severe mental illness here in Los Angeles. She is now the director of the UCLA DMH Public Mental Health Partnership, which provides training and technical assistance to clinicians who care for individuals with severe mental illness. And her research has been focused on community-engaged participatory approaches, and she's going to share a lot about that. On a personal note, I'd like to say it's been one of the privileges of the last 2 years to meet Beth and to get to know and work with her. We've sort of come together around opposite ends of the continuum. My work has been in prevention and hers working with people with severe mental illness. The expansion of UCLA's partnership with Los Angeles County Department of Mental Health and other Los Angeles County systems align with a transformational inflection point within the county and the state, one in which our public institutions are working together in a sustained and deeply engaged partnership towards transforming our public systems to improve mental health prevention and treatment services for those living with mental illness as well as their families. Beth's work, as you could hear from her bio, and her current work with the Mental Health Partnership is at the forefront of these efforts. And she's really, I think, the perfect person to be leading this effort. She is unflappable. People come to me and say, I don't know how Beth does it. No matter what's happening, she's always calm. She always has good humor. She's always creative, and she always problem solves in a rigorous and generous way, even during our very challenging startup work with community system transformation. So I look forward to your talk, and I look forward to working with you over the next few years.
Well, the pleasure is certainly reciprocated. It's been an absolute delight to get to know Tricia over the last year and a half as well. Thank you, everyone, for coming. It's really a pleasure to be here to be able to tell you this story. I'm just going to dive right in. I have a lot of information, and I think as we go, I hope to give you a feel for not just what I've been doing, but what's happening in our community, this community, and in LA County, and a little bit of a vision for the future, I think, that comes with it. So my focus here in the talk is to give you the basics of the Public Mental Health Partnership, a good sense of who, what, where, and why we are, what we're doing, and particularly with a frame around PMHP as a campus initiative, a departmental initiative, our involvement in the way that we as a department are engaged with DMH. And then I'm going to talk at length, actually, about how we've begun to conceptualize the role of the PMHP as what's called Intermediary Purveyor Organization. And I'll give you a sense of why I think a conceptualization of our role can be very helpful in this work with DMH. And then give you some examples of the kinds of activities we're engaged in with 2 clinical programs at DMH, full service partnerships, and the home teams. So first, just the basics. The DMH-UCLA Public Mental Health Partnership is a contract funded by DMH. It's located within the Center for Health Services and Society and the Semel Institute. It's funded by California Mental Health Services Act dollars, specifically workforce, education, and training dollars. We started in October of 2018, so we're 13 months old. And we are renewed year to year, but we're a component of a multi-year DMH-UCLA collaboration that the LA County Board of Supervisors has approved. And we have various advisory boards and oversight actors who help us to unfold the project. We, as Tricia alluded to, we sometimes talk about PMHP as a public-public partnership. In fact, public-public partnerships are most frequent in international development work. They're called PUPs, which is very cute. And in international development, the concept is intuitive. It's just a partnership between two public entities, typically for the purpose of sharing services and transferring expertise. These are mostly applied in areas like water conservation and natural resource economy. But this kind of framework of a public-public partnership does strike me as somewhat relevant to the way that we've been thinking about the public mental health partnership. The Transnational Institute is one organization in international development that supports public-public partnerships, and I really liked this description they have of them, a peer relationship based on solidarity, forged around common values and objectives, which excludes profit seeking. Kind of rings true to what we're doing as well. And I think what comes with that is an expectation that UCLA will be a careful steward of the investment from DMH and the state and the Board of Supervisors. So what do? We support 2 DMH clinical programs as well as a slightly broader group of system programs. And we support direct service providers by providing training and technical assistance activities that aim to improve the quality of care, increase accountability, and enhance system capacity across the county. And we do that while we're engaged in a transparent, mission-focused, and trusted partnership with DMH that generates benefits for us at the university and for the public. This is the work of an amazing, dedicated team of people who in the last year really have just dove in headlong into a pretty rambunctious, sometimes a little chaotic, difficult to comprehend activity that is still emerging and transforming kind of day to day. And it has been such a pleasure to bring, this is our direct UCLA team, to bring this UCLA team to focus on the set of activities that I'll describe for you. This team really brings an amazingly diverse set of expertise and experience. Is it buzzing a bit? Lisa Davis, who is a social worker, has a doctorate in social work as well, was at D.D. Hirsch Clinic for many years, leading the research and evaluation unit. Elizabeth Mackey came from New York City, an organization called Community Access that has focused on peer support and peer services for several decades. David Hanick worked in New York City at an organization called ICL, which runs ACT teams, homeless outreach teams across New York City. Hannah Mark was previously working at the VA in DC around quality improvement efforts. So you can see we have Jean Lundquist, a brand new member of our team who started yesterday. We really, it's been an amazing experience to bring together such talented people to focus on the work that we're doing. But that team, as capable as it is supported really by a whole array of other partners that have been so important over the last year to help us figure out how to proceed, what we're doing, where we should move, what the priorities ought to be. And those are DMH system partners. So this group of individuals here who run programs or run clinics at DMH, some frontline providers who know the work extremely well. We have a set of contract providers. As I'll show you, DMH is a really diverse system with both directly operated clinics and contract clinics, and we try to link with both. So we have a set of partners who work in contract clinics, help keep us abreast of how they understand the issues. And we work closely with E6 leadership, which I won't talk a lot about today, but E6 is the coordinated homeless outreach plan for LA County, part of Prop H and HHH. E6 coordinates the work of all the homeless outreach teams in LA County. They're an important partner for us. It's really brought to mind for me the way UCLA is a collaborative effort. All the other pieces of the university have been really critical to getting this partnership going. And then an array of community partners that we work with, and a set of academic partners as well who offer investigative support, help with knowledge generation, and also creating some trainings. So why is the PMHP, this expansion of the relationship between UCLA and DMH, why is that happening now? I think there really are two reasons. One of them is time sensitive, and that is that there is right now in LA County the political will, public attention, some leader drive to address some of the issues that we look at in the Public Mental Health Partnership. Everyone is pulling in the same direction. I think it was out of that will that the PMHP emerged. At the same time, there have been long-standing and well-documented challenges moving evidence-based approaches into public mental health settings. And that is the problem we work on at the PMHP. So we're all aware of the public attention to the issue of homelessness. The two programs that we work with focus either exclusively or extensively on homelessness. The full service partnership programs, about half of the clients enrolled in full service partnerships were homeless in the year prior to enrollment. They focus a lot on maintaining housing. So we I think, came on board in order to focus on this problem that's getting so much attention. And as I said, there are well operationalized, clearly efficacious interventions for severe mental illness. This is one list of them. Others may have a slightly longer list. One way to think about what we do is that we want to see these interventions available for everyone with a severe mental illness in LA County. But we know from data from multiple sources that the penetration of evidence-based interventions in public mental health settings is very low. This is a survey that SAMHSA conducts every year, the National Mental Health Services Survey, simply a self-report of clinical sites. Do they offer this intervention or not? You can see that peer-run services, supported employment, evidence-based approach to supporting employment and education as well, illness management and recovery. So the penetration is very low for all of these, and this is simply based on self-report. If you actually went to the site and you look to see what are they actually doing, you could expect the implementation would be lower than reported here. So I want to talk for a bit about this concept of an intermediary purveyor organization. It's how we've come to see our role with DMH, in partnership with DMH, and thinking about the PMHP as an intermediary purveyor organization has been very helpful in ways that I'll illustrate for you. So in the implementation science literature, there has been the characterization of this organizational model called an intermediary purveyor organization. In fact, there are two different types of organizations, we could say. One is a purveyor organization, another is an intermediary organization. And a purveyor is an individual or group of individuals representing an evidence-based practice that work to implement the EVP with fidelity and good effect. So purveyor, you can think of as a shop that focuses on one particular evidence-based approach. They know how to train to that approach. They understand the implementation strategies that help to move that approach into real-world settings. And that's what they do. They focus on implementing that one EVP in public settings. Some of these are nonprofit organizations. Some universities do this purveyor work. But that's the sort of classic model of a purveyor. An intermediary, on the other hand, is an individual group of individuals that acts as an intermediary between two or more entities to promote the implementation of model programs with fidelity and good effect. Simply sitting in between, could be sitting in between a purveyor organization and the service system. And the aim of the intermediary is to understand how implementation can work for that particular service setting. The intermediary organization in contrast to the Purveyor, assumes a much broader role to promote implementation. They don't focus on a single EBP, they focus on the range of EBPs that may be helpful, and they try to figure out how to move those into the service system setting. So this is our model of an intermediary organization, which is what we call ourselves for behavioral health care. It's the model we have developed and are using, still iterating and evolving this model to a certain extent. Lisa Davis has been really spearheading, kind of clarifying the elements of this model and how they work for us and how they might be helpful for other kinds of organizations in a similar public-public partnership. And I'm going to walk through this. We'll spend a little time on it, walk through it in pieces for you. We can focus, first of all, let's talk about the title. We do think of ourselves as an intermediary organization rather than a purveyor organization. But I think we're aware we may begin to do both kinds of things. There are times when we have an evidence-based approach, we want to move into the system, we might function a little more like a purveyor. Right now, we're really a kind of classic intermediary organization. So the two inputs, both of which are very important, are academic and technical expertise. So this is evidence-based, the knowledge of evidence-based approaches, technical experts who can train and teach and translate that approach, and then a whole array of community stakeholder input that's really critical to understanding how we should frame our work. So this is not only provider input, also community partner input. And that's easy to understand. These shape where we focus our time. The impacts we aim to have are also easy to understand. Not only do we want to impact how service is delivered at the clinic site, at the service agency level, but also we have some impact on the service system as a whole. So not just at the interface of the clinic, but also the system around it and how it gets supported in that system. And then, of course, aim to have broader impacts on the community as well. And these can be a range of things at the level of the service recipient, the patient or the client and their families, at the level of service system organization and culture, at the level of the service provider, knowledge and skill, and at the level of the community in terms of well-being. So the output, straightforward, but we think about all these levels. The inputs, not just this piece of technical expertise, the ivory tower, but also what people on the ground are telling us about what's going on. And then I'm going to go into more detail about this middle box, but essentially this talks just about the discrete activities that we focus on, the objectives they aim to serve, and the higher order mission that we think about. Realizing a vision for excellence in care for vulnerable population that incorporates typically marginalized perspectives and builds capacity to foster health equity. So this is simplified with just the activities we engage in the middle box. Pretty straightforward, right? We do some consultation, both at the clinical level and also around trying to understand which sorts of resources might be needed, some technical assistance activities I'll describe for you, training and education, of course, we do that. We think about developing best practice models that are relevant to the system. We help with quality monitoring strategies. And we do those things in the service of this set of objectives. And I think this is really the meat of it, and this is where we generate added value in functioning as an intermediary. So while we pursue those activities, we are thinking about ways to sustain policy practice and systems change. We're thinking about ways to support knowledge and skill building at the community, organizational, and individual service provider level. We're thinking about negotiating evidence-informed strategies that fit service system preferences, culture, and context. And we raise tough questions to drive collaborative service system problem specification. Problem specification is, to a certain extent, a thing we think about a lot. Can we, with DMH, with the service providers on the ground, with the leaders who are planning programs, can we collaborate in order to identify the key problem so that we can find the right solution for that problem? So I'm going to illustrate for you how these kinds of objectives and activities shape our tasks as I walk through some of what we do with FSP teams and with home teams. So this is our whole model of an intermediary organization. Now, it's actually pretty common that a large public system implementing a complex intervention for a complex clients like assertive community treatment, that they have some degree of support. This is just some example of the academic centers that are much like an intermediary purveyor organization that we've established here in the Public Mental Health Partnership. And when you look at the way they describe their work, it's very similar to how we understand our work with the county. The Center for Practice Innovations at Columbia is one example. Delivers a wide array of training to increase the competencies of the New York State behavioral health workforce. Their partner at CPI is New York State, as opposed to the partner of LA County here. North Carolina as well. Our vision is that all North Carolinians with serious mental illness will achieve the fullest recovery possible. The ACT Institute in Indiana, Research and Training Center focused on evidence-based mental health practices. Similar kinds of missions and approaches that other universities have taken in partnering with public systems. So one thing you notice in the literature about intermediary organizations is some preliminary understanding of what helps them to succeed. And I liked this set of factors from an article about IPOs. The impact of the political climate is very important. So political climate in which the service system is embedded can make a big difference on whether that intermediate organization can succeed, and the influence that that political climate can have on political will and the readiness to allocate resources, stakeholders' willingness, as stakeholders from the university and also from the public system, their willingness to work collaboratively with one another and with intermediaries, of course, is a key factor in success. Also, the historical experience of previous initiatives and their success or failure. Many of us in this room are aware that UCLA and DMH have worked together before. Sometimes those relationships go really well. Sometimes they don't go so well, a little bit rocky. Those kinds of things do make a difference on any further initiative down the road. That's what this bullet is intending to convey. And of course, the needs of the system, so the needs of DMH, for instance, its capacity and leadership support for change can make a big difference in the intermediary organization success. And I put these in two different colors because I think the ones in gray on the left are the ones that we at PMHP and also at the university as a whole have more control over. So we are a piece of the political climate in which the service system is embedded, certainly a piece of the political climate in which public mental health partnership is emerging. So the degree to which we are a good partner makes a difference to success for the intermediate organization. And our willingness and our ability to continually collaborate with one another, work through the strengths on both sides, recognize where there's a way forward is really critical to success. Okay, glad I still have a good amount of time because I want to tell you now about some of the activities that we've done over the last year with FSP and home teams. So one of the largest program that we work with is the Full Service Partnership Program in LA County. And full service partnerships were funded by the Mental Health Services Act, continue to be funded by the Mental Health Services Act, which passed in 2004. So most of the teams emerged around 2004, 2005. FSPs are multidisciplinary. They use a team-based approach. The approach is much like assertive community treatment. And this is a long story, but FSP is intended not to be ACT. And they don't think of themselves, especially at the beginning, but to this day, it's still somewhat true. They don't think of themselves as following the ACT model, yet they share a lot of the features of an ACT team. About 7,000 clients served by adults served by full service partnership teams in LA County. That's 18 and above. There are about 80 sites, 57 contract agency sites, 25 directly operated clinic sites that run FSP programs. Again, the FSP program, it's a largely contract program. DMH runs its own clinics. 25 of them have their own FSP team. And then DMH contracts out a lot of that work to contract providers, also called legal entities, agencies, D.D. Hirsch, Pacific Clinics, The Village. These are contract agencies. They also run their own FSP program. Complex, very diverse, varied program of FSPs. About 50% of the contract provider programs serve fewer than 50 clients. So served community treatment is a team-based model. You have a set of multidisciplinary providers who work with a panel of patients. If you are only serving 50 clients or fewer, you don't really have a team around those clients. It's a very small program. So our sense is that those contract programs that are very small, serving 50 or fewer clients, they don't really function as a team. They do something a little bit more like intensive case management, perhaps, but they're not really leveraging the full potential of a team-based approach. And that actually has become, in the last few years, one of the targets for what's been called contract transformation. DMH would like to move all of the FSP sites to something a little bit more like a consistent team-based approach. And we've been involved with them in thinking about not only the contracting language to move in that direction, but what that team-based approach looks like, what it consists of, what's important about it, how we train people to operate in that way. But just to point out, that's a big mission, a big shift will require a big change for the system as a whole. So just to give you a flavor of the sorts of things that we're doing with adult full service partnership programs, this is the set of objectives that we have in our conceptual model, an example under each of the activity that we're engaged in to further that objective. As I mentioned, we are supporting transformation of FSP to a team-based model. We're doing that both by working on what the contract language could look like, offering strategies used on ACT teams that may be relevant for an FSP team. We're writing a manual that can help all FSP providers understand what a team-based model looks like. Also in the context of FSP, we're doing a lot of negotiating evidence-informed strategies that fit the service system. So this is, as I've been describing, a far-flung and diverse, fragmented system. Finding evidence-based approaches that can be implemented with adequate fidelity in a system like that as a whole is not simple. And you run the risk of undermining some of the strengths in that system. So there are sites that have developed really exciting, innovative, effective strategies that are informed by evidence-based approaches. And our work is to try to figure out where there are sites that are ready to do more around that evidence-based approach or evidence-informed approaches that can be readily integrated into the system as it exists, and thinking through with DMH what their priorities might be around that. One of the objectives I mentioned in our conceptual model, raising tough questions to drive problem specification. One example of that is the conversation that we're having with DMH about data strategies, that they can monitor outcomes and processes in their FSP program in a consistent way that can help them move toward quality assurance and quality improvement over time. And finally, of course, most simply supporting knowledge and skill building among providers in the FSP program, offering training tools and workforce support. So I'll show you a little bit more about all of these activities. I've mentioned some of them already. Advising, working with DMH and their other partners to operationalize the target population for FSP. Who should the teams be enrolling? How should they build a team? What are the staff roles on all the teams? What's the ideal staffing model for the contract? Once you write it into the contract and you ask your contract clinics to do it, that's a form of accountability. So we're working with them to figure out what the language in a contract can do to move this large system toward a consistent team-based model. We are developing an FSP fidelity scale so that teams can self-evaluate. Lays out the kinds of processes and practices that are common on very high quality teams. Everything from how they manage housing issues, how they work with clients around medication, how they layer in recovery-oriented approaches, fidelity scale allows the teams to understand the ideal vision for the team model that they're working with and see where they are on that scale. As I mentioned, we're working to write a manual. So in addition to the contract, which is, of course, contract language about what's required of a program, very important for providers to be able to grasp the sort of intellectual underpinnings of a model like FSP, the intellectual framework for the treatment intervention itself, some of the less tangible aspects of running a team. And we're using the manual as a way to articulate that more thoughtful approach and then make that available to teams. So you would think that would already exist. It does exist to a certain extent, but we're taking what's already there and trying to make that more rich as a resource for the teams. And then we're developing or curating. Either we're developing trainings or we're bringing in other trainers, and we are delivering or hosting trainings on core and specialized topics that are relevant to FSP. So let me show you the core topics. I'll do this first. Thinking about an FSP core curriculum, what are the key things that every FSP provider ought to understand? This is the model that David has developed, person-centered, recovery-oriented approaches, trauma-informed care, harm reduction, field-based and systems-oriented care, how to work on a team, how to be in the field, how to think about the whole system you're embedded in. Those are those sort of inputs for a core curriculum for full-service partnerships. And got out of order, and now I'm not sure what to do. Related to that, not just the core topics, but what are the core evidence-based models that we think are important for FSP teams to understand? So what do we put in the manual? What do we describe in the manual? How do we describe this model that is evidence-informed? It's not quite the same as what we think of as a classic EBP. It incorporates a lot of key components of a variety of other EBPs, and I've listed them here. Observed community treatment is probably the main one. FSP borrows the most from ACT. Also incorporates some elements of housing first, of harm reduction, supported employment, illness management, recovery. So these are the sorts of evidence-based approaches we think are important for FSP providers to understand. So one of the things we did last year was have a FSP conference so that all the providers from all the teams across the county could come together for a day of training on key topics. You would think this happens all the time, and it actually doesn't. FSP providers in DMH do have trainings available to them, but they tend to be one-off trainings on one particular topic, and they don't always have a chance to get together with other FSP providers, especially FSP providers that work in directly operated teams and those that work in contract teams. Those two pieces of the system tend to be fairly segregated, so an opportunity for them to come together and understand what they do that's shared and in common is quite unusual for them. That's what we tried to do in our conference in May. It's just a list of some of the topics that we had in that day-long conference, a lot of different breakout groups that we used on that day, and we had 365 providers come for the conference. And then after the conference, we make all of the presentations, both in video form and the slide deck, as well as in a podcast form so that you can listen to the audio. We make those available on our website so the providers who couldn't come that day, and we think it's about 60% of the FSP workforce who were not there at our conference last year. Those that weren't there can download, view, listen to all the presentations from that conference, and we'll continue to use that strategy as we go forward so that people have the teaching and training available to them. In addition to the conference, we're starting in January what we call training collaboratives, which are intended to deliver core training topics to all FSP providers. These are day-long trainings taught by our PMHP UCLA staff, and we do them 8 times. We do them in all 8 spas because it's just not possible to get everyone across LA County from Spa 1 Antelope Valley all the way down to Long Beach in the same place for one day. It's asking too much of them. So we do it 8 times. We'll probably actually do it 10 times. We have a couple of extra trainings in those service areas that are particularly large. And we teach the core FSP curriculum, and we're starting with person-centered and recovery-oriented care in January. And these will be followed by some check-in calls and an ability to focus on this topic for the quarter as we interface with teams in other settings as well. And then soon we will have available a set of online modules for all FSP providers. So these are online training modules created by the Center for Practice Innovation at Columbia that I mentioned to you. Core FSP topics around things like trauma-informed care, motivational interviewing, harm reduction, integrated care for substance use, integrated care for medical illness. Those online modules will be available to all FSP providers quite soon. And in addition, we do what we're calling specialized trainings for some special audiences, not all FSP providers and not a core curriculum, but specialized training activities that may be highly relevant for particular groups. We're thinking a lot about team leads and supervisors who will need to be very savvy about how to move to a team-based model or how to support the team that they have. So we have trainings designed for them on running a team, what a team can look like, and a learning collaborative, which unfolds over many months and includes some homework in between that will start in the spring with those team leads that focuses on team function. And then we're kicking off this week Training Champions program. We actually have 3 champions from last year who carry forward, but officially launching our Training Champions program this week, which brings in some exceptional, very experienced FSP clinicians to have an intensive training experience either with us or in conjunction with us or at conferences on a topic they're very interested in so that they can be ready to take that back to their peers and colleagues in training contexts. We're also investing in a few activities we feel may build the workforce for FSP, interesting psychiatrist in FSP work, and a pilot for occupational therapists who may be interested in working on FSP teams. Hopefully next year, a pilot of advanced practice residents from occupational therapy who can work on FSP teams, and some work around peer specialist training. So that's the end of FSP. I'm going to shift a little and talk about related kinds of activities we're doing for the home teams. So home teams are homeless outreach and mobile engagement teams. They do homeless outreach. They are DMH teams doing homeless outreach. They work in all 8 spas. Home is actually the merging of 2 separate homeless outreach teams that came together over the last few months. And they work alongside, it's about 800 homeless outreach specialists employed by various entities, public and nonprofit, doing homeless outreach across LA County. So there are DMH teams, home teams, there are DHS teams, there are LASA teams, there are business improvement district teams, other nonprofits have homeless outreach teams. They're all doing outreach work with those who are living on the streets unsheltered. And in that context, you can imagine DMH teams, the home teams, is a little bit of work involved in figuring out their unique role as a mental health team doing outreach, who specifically they ought to be serving, and what their goals are going to be in that outreach. And they work with 44,000 unsheltered individuals in LA County. And their aim as a DMH team is to link those 44,000 individuals to mental health services. Ambitious, yeah, but that is the aim of homeless outreach, of course, and the aim of DMH homeless outreach teams. So our support with the home teams focuses on the same kinds of objectives. So thinking about policy and system change as it relates to home and homeless outreach. We share evidence with them. We identify best practices with them that may fit their work. We try to identify high-value research questions that could support the work of the home team and drive policy. We try to raise tough questions with them about how to work with such an enormous population in a way that is efficient and that minimizes risk. So we've advocated for a public health approach to outreach, which I will tell you more about. And of course, we offer tools, training, and workforce support in a variety of ways to the home teams, as well as to the other homeless outreach specialists that they work with. I'll show you some of that. So we provide core mental health trainings to all outreach workers. These are core trainings: motivational interviewing, trauma-informed care, housing-based case management. They are provided by an organization called CUCS in New York City. And they come here and they do day-long trainings for homeless outreach providers from a variety of different contexts. And then we offer some specialized training to home teams. We're developing what we call a homeless outreach behavioral screen that helps generalist outreach workers identify who may need specialized mental health services. And we're thinking about how to count, how to get a better sense of how many individuals living on the streets do need a specialized mental health intervention in order to gain housing. And we're working on a manual too that might codify some of this approach. So just very quickly, one of the main challenges of homeless outreach for DMH is triage, is figuring out who to help first and why, and finding those who are at highest risk for morbidity and mortality because of their mental health issue and the fact that they're living unsheltered. It actually requires a great deal of intentional effort to frame the work toward the right target in order to make a difference and to minimize the number of individuals who die on the streets. And really, this is why. So New York City, total homeless count, almost exactly the same number as in LA County, just a couple months apart. But New York City has an extensive shelter system and a tiered shelter system. So the vast majority of their homeless individuals are sheltered, and often they are sheltered in a site that accounts for their level of morbidity, whether they have a mental illness, whether they have physical health difficulties, whether they need support for functioning. And they work with a much smaller number of individuals who are living actively on the streets. And they actually know those who are on the streets are those that may have the most difficulty living indoors, often because of their mental illness, that they need special sorts of support. So they get to focus on 3,600 individuals who are unsheltered. In LA, because we don't have housing resources and the vast majority of our homeless individuals are unsheltered, we really struggle to figure out who it is who has the highest level of pathology and could most benefit from an intervention, and particularly who could most benefit from a mental health intervention. So this just presents a challenge of triage for LA County that's unique in the country for sure. So one quasi-experimental approach was used by Pacific Palisades. They developed a community task force on homelessness. They partnered with a nonprofit, and they offered a housing first approach to all the individuals who are living in the Palisades, and they counted how many they were able to help. First, they did a count. They had 157 individuals living in the Palisades who they thought were sometimes there and sometimes not there. Then they identified 134 of those who they thought were most all of the time living in the Palisades. They engaged 86 of those with this housing first approach and some housing resources available to them. They were able to house 69 of those 86. 17 of those they found very hard to help, and 8 of those 157 they found extremely hard to help. And of those 8, sounds pretty clear that most all of them had an active psychotic illness that was interfering with their ability to engage with the teams. So if you extrapolate those numbers to what LA County faces, we've just been thinking about this as a model. We might say there are about 3,000 individuals on the streets in LA County who we would call extremely hard to help, who may need a specialized kind of approach and intervention to move to safety. And I have just enough time to show you our video. So this is the population health approach to outreach that we really want to focus the home teams on, figure out how they can really hone in on those who may need their services the most, and develop some training tools for them so that they can advance that strategy. One of the other things that we have done with the home team and with the homeless outreach sector generally is to find best practices from elsewhere in the country, really to kind of open up a vantage of what might be possible to do in LA County. And we've sent some visitors to New York City to do site visits. We've done 3 visits now. We take 8 people, really highly choreographed, couple of days, site visits, reflection, discussion. And I want to show you a brief video that we've created from our site visits that I think gives you a flavor of what happens when we go to see what another system has come up with and how it might apply and work in LA.
The first day I went to the Queens Drop-In Center, which is run by Breaking Ground, and they do a lot of street outreach. So what I was really struck by in talking to the director and going out with one of the street outreach teams was just the fact that basically every street-based homeless person in New York City seems to be accounted for, and that's the goal, is to have them accounted for. So they have relationships with them, and they've got their census, and they're keeping track of them, and they're trying to engage them, trying to offer them housing. That alone seemed really remarkable.
Safe haven. Because it has medication management, and it's more for mentally ill. It's smaller and private.
Sort of like a mental health shelter.
Exactly.
Yeah.
You don't actually need a hospital. It's just in LA we only have a hospital.
Right.
That's the only
Right.
place we think to bring them. That was my big realization. I was like, I don't understand. Like, you can't. And they're like, well, we can bring them to this safe haven where like they don't do meds, but like you can go get your meds, and someone will clean them, and
they can
there's a primary care doctor, and I'm like, oh, well, like then of course you don't need to go to the hospital.
Right.
Yeah. So the idea is that you're in a safe haven temporarily while you get your housing package in line. Every person to get a housing package has to see a psychiatrist.
Yeah.
To get their housing package complete.
Yeah.
And I think that's the thing in LA that's missing. All of a sudden you have this person who's housed, and then something happens, and no one knows what's wrong. Well, no one even knows how to intervene because they don't know what's wrong with the person.
Triage.
Yeah.
Like no one knows if they're an alcoholic, no one knows if they're psychotic, no one knows anything.
The why,
Your experience there.
to me, the biggest thing that stood out there was that it was an interesting clinical situation where the psychiatrists have talked about it being almost like an inpatient ward, because people live there, you have access to them pretty easily. So you could see somebody multiple times a week. You could change medications quicker. You could be a little bit more aggressive and do more stuff. And we have 3 residential facilities at D.D. Hirsch. So it's kind of made me rethink a little bit about how we might work with those facilities.
Just a snippet of some of the reflections and learnings from seeing other sites. And then just finally, the core thing we do for home and also for the homeless outreach providers is make high quality trainings available to them. This is just a picture of the trainings we're offering for homeless outreach teams as a whole, those 800 outreach workers that I mentioned, some core courses, some elective courses, and some topics that are specialized for home team. These are day-long trainings, 81 days over the fiscal year, and we do them across LA County in the different spas. Just an example of some of what we've done so far. Almost 2,000 homeless outreach workers have attended our training since we started in March. Tend to be very, very satisfied with the level of the information in the training. And we've really reached across a whole lot of different agencies and different sectors who are working with homeless individuals. So I would encourage you to go to our website, which lists a lot of what we're doing, the training offerings we have available. That's what's here on the right, is just a picture of our calendar page of the trainings that are available to different audiences. You can see they occur in a lot of different places. These happen to be on the west side, some of them, but we kind of vary them week to week in different parts of the county. We have some videos, including the full video from New York City, available on the website, and some other updates and news about the center. And I really just want to thank you for your interest and welcome your comments and thoughts and suggestions. This is very much an emerging and evolving kind of project that's intended to bring all kinds of expertise from UCLA to DMH, and I would really welcome your ideas about how to do that well. Thank you.
This is a very important moment in the Institute's history, this period of time. Early 60s, it opened in 1957. Somebody had a prescient vision. There's two mental hospitals, which were also educational institutions. That was the one at UCSF and the one we had in Los Angeles. So for the first 20 years, the Department of Mental Health, then called Mental Hygiene, ran these two institutes, yes? Those two institutes then, in 1974, were essentially under threat because of the changing manifest in terms of the state governorship. It was Governor Reagan, and then later, of course, he was president, and the mental health programs in general took a swipe. But that was when they migrated into the university. So this institute became part of UCLA, and the one at UCSF, called the Langley Porter, became part of UCSF. Fast forward, we're now back in a renaissance where, in fact, the integration of county programs and the institutes will rejuvenate, because the governor seems to be very interested in this. We have all sorts of people, some of whom are in the room. I see Joel over there, all of whom have worked towards this integration of county programs with the university again. We now have a lot more resources in terms of intellect, but what I want to just emphasize is that the institutes and the county and all the things we do, not only in terms of the way in which we're beginning to think about the homeless, but also in the way in which we begin to think about how mental illness perpetrates itself. If you think about those, the Institute's intellectual, academic response, training the next generation, of thinking through the, the pertinent research that we have to put on the ground, not only from the standpoint of the socio-cultural research, but also what drives these illnesses. Those things, when they come together with a truly outstanding county-based mental health program that potentially go across the whole state. We had something called the Center of Excellence here, started when Darrell Steinberg, who's now the mayor of Sacramento, was the senator pro tem, that's the head of the Senate. That still exists, and he's still working on that. All these things come together in a way that is unique. The other thing that is happening, and this is a great tribute to the leadership of the residency programs and the other programs, training programs, is I think we're now, for people coming into psychiatry and psychology and other of the mental health disciplines, are beginning to realize that this is a true calling. And we can now put these together in a way that we haven't been able to do for a long, long time. So when you hear Beth Bromley's talk or Joel's talk, or you talk to Patricia about some of the things that she's been doing with the armed forces, and now more recently with the counties, really that is the implementation, that is the practicum of what the Institute should be doing. So this is almost a party political speech, and I'm going to shut up so you can ask questions. But the fact is that this is a very, very important moment in the evolution of American psychiatry. Just think of it. Why should we have 56 to 60,000 people on the streets who are mentally ill on and off, whereas New York seems to have managed to figure out where they all are? Well, you can blame the weather, But beyond that, we really need to get ourselves together, and it's coming together right now. So I'm going to sit down, and there may be questions. I'll stand up, and there may be questions. Yes, Jim.
Should I just shout? Yeah, I guess I will.
Yeah, why don't you?
No microphone.
Well, the microphone, is that one working? Oh, good. Give it to this gentleman here, if you would.
Yeah. So when you were talking about those contract services, the clinics that are serving, roughly 40% of the patients, and you're and I'm thinking I work for one of those, pretending I do. And now you're saying to me, these 47 people that we've been treating for the last 8 years would do much better if you had a team. And if you don't put together a team, your contract is over. So the question I would ask you is there solid evidence that a team approach is as or more effective, and is it as or more efficient in terms of cost, given the outcomes that you want to obtain?
Mm-hmm. In fact, there's really good evidence about that, in particular with this client population, that their needs are so complex that they need medication management, they need some supportive approaches around education or employment, that they need some help maintaining their housing, and they need help with benefits, they need help working with their family, reconnecting. There's an array of needs, and that when you bring multiple disciplines together around that array of needs so they can coordinate care, the outcomes are better. That's pretty consistent in the ACT literature, that those teams that are higher on those measures of high team functioning do better for clients. The other element of it is that the providers doing the work feel better. They feel more support. They have more opportunities for deliberation around the nature of the work. They come to better solutions. These are things we know from practice, that when you can synergize the work of a group of people around complex clients, the providers themselves feel better. But the other thing I would say in response to your question is we don't, neither DMH nor PMHP, intend to go to those sites that are not working as teams and say, you must now work as a team to help these 47 clients. We try to look to see what are they doing that's working for them and why are they doing it, and what's possible for them within the enormous constraints of billing, resources, time. What element of it can we have them pick up that they might see as applicable to their context so they can move toward a team-based model consistently?
Thank you.